spin. So a test with high specificity, when the test is positive, helps you to rule in the diagnosis. Again, if you want to believe a positive test, you must minimize false positives. To do this, you must have a test with sufficiently high specificity. And notice I say sufficiently high. I don't specify how high that is, because you'll see in a minute that the pretest probability has an effect on this, on the post-test probabilities. Now, does sensitivity affect positive predictive value? Yes, but it's not as big an effect as specificity and pretest probability. Now, what I'd like to do is to show you a schematic about what a diagnostic test actually does for you. So this is the probability of disease, 0% and 100%. Now, before you do the test, you have some probability of disease. That is called pre-test probability. What's the probability to have the disease before you do the test? Now, if the test is positive, if it's a good test, you're going to get a boost in the probability of disease, right? And if it's a good test, it'll go up by a lot. And then if you have a negative test, the probability is going to be pushed down. Okay? So, So what is this number up here? This is the positive predictive value. It's the post-test probability of disease after a positive result. What is this post-test probability of disease after a negative result? What's 1 minus negative predictive value. So now what we're doing is we're using these positive and negative predictive values in the schematic to help you see what's actually happening. Okay? Now, if you go from a pretest probability all the way up here, almost to 1, to a point at which you could say you've ruled it in, okay, that would be a test with high specificity, right? And if you have a negative result and you have a high sensitivity, it's going to go down near 0. But not all tests have high sensitivity and specificity. So what would happen if you have a test with lower specificity, it would end up down here. Okay? And same thing here. If you have a test with lower sensitivity, it's not going to push this down as far. All right? Now I'd like to do a quick exercise, because I think it's useful. There's something called Bayes' theorem, and I'm not going to go into exactly what it is, but essentially this is Bayes' theorem, okay? And I'll show you how that works. What Bayes' theorem says is that the pretest probability can have a profound effect on the post-test probabilities of disease, essentially, okay? Especially if the sensitivity and specificity are not near 1. The closer they are to 1, the less effect the pretest probability has. But if it's not near 1, the pretest probability has a very, very profound effect on the post-test probabilities. So using positive and negative predictive value, therefore, properly, it requires an understanding of how to estimate the pretest probability. Okay? And you should not base your trust of a test solely on the sensitivity or specificity of the test. Especially if they're not really close to 1. Okay? And especially if you're surprised by the result. Okay, I'll show you how that works. So, what is this pretest probability? Well, let's go back to our study, this study that looked at catheterization as a gold standard and exercise stress test in diagnosing coronary artery disease. The pretest probability is the prevalence of the disease. So it's literally this 219 over 352, what we talked about before. Okay. In this example, the pretest probability is 62%. Okay? Now, so the pretest probability in the setting of a diagnostic test validation study is the prevalence in that study. But you don't have the luxury in your clinical office to have 352 patients sitting in your office, right? So what this pretest probability is actually your estimate of the probability of disease in a given patient before you do the test. And you start saying, oh boy, I have to estimate something that sounds really imprecise and maybe inaccurate. Okay. So what I want to say is that the pretest probability or the prevalence can have a profound effect on the positive and negative predictive values. What happens is the positive predictive value is maximized by a high pretest probability. The negative predictive value is maximized with a low pretest probability. Now, do you really believe that you can do this? Can a physician really estimate the pretest probability? What do you think? Yeah? Okay. Well, let me go back to medical school. Okay? And in medical school, I'm going to make several statements. You tell me if you believe it. Okay? So the professor says, students, the history and physical examination form the foundation of the physician's clinical judgment, diagnosis, prognosis, and therapy. Right? Do you remember that? The Bates book. Your clinical exam is far more powerful than laboratory tests and radiology studies. Do you believe that? Kiddish. What are you talking about? Or how about this? The ability to judge the pretest probability of disease is one of your most valuable tools. So you may be skeptical about this. There are some people saying yes, some people saying no. But let me demonstrate what I'm talking about. So if you see a 65-year-old man in your clinic, what test are you going to order? Okay. Tell me, do you think should you get an MRI of the brain? Or a urine culture? I know, a full body scan. Full body scan. That'll do it, right? And you order it, and they get an appointment 2 months from now, and 2 months later you get your full body scan, right? Okay. So right now, how many diagnoses are on the table? Tens of thousands. Okay. Well, this man, he's 65, and he's a man. He presents with recurrent chest pain. You say, what's your chief complaint? Recurrent chest pain. Oh, it happened 7 times in the past 4 months. Okay. Now, tell me, what just happened to urinary tract infection? Because that was up there. That was a possibility in a 65-year-old man. So what just happened? What happened to the pretest probability of urinary tract infection? What happened to GERD? Went up, okay. What happened to angina? What happened to pneumothorax? Okay, so then now he says it's sometimes exertional, sometimes seems pleuritic, usually lasts 10 to 20 seconds, sometimes longer, not associated with diaphoresis or lightheadedness. It lasted about 10 minutes this morning after climbing and trimming his date palm tree. It was a bit, we would like a bit tree, right? So, all right. Now what just happened to pneumothorax? Went down. What happened to GERD? Down. What happened to angina? Okay. So do you see what you're doing? And within, how long did this take? 2 months to get your MRI? Literally, it took 5 minutes. And what did you actually do? You see, people think the clinical exam or the clinical history is a sort of passive, why are you here? Oh, tell me. No, it's a very active process because you've got so many diagnoses on the table. And what are you doing? You're pushing some down and pushing some up with every question. And in fact, every question is a diagnostic test in itself with a pretest probability and a post-test probability. You see? Does it radiate to the shoulder? Yes. You see what I'm saying? So that's a very active process, and by the end of 5 minutes or 10 minutes, you can have, what have you done? You've taken tens of thousands of diagnoses, and you come up with 3. Now that's pretty powerful. Is there any MRI or any test that can do that? No. So that's why, the Bates book says this is your most powerful tool that you have. Okay. So what would you rate this man's pretest probability that he has heart disease now? Would you say it's 20%? Would you say it's 50%? Would you say it's 70%? 90%? Well, no, but you're dealing with this patient. He has chest pain 7 times in 4 months. It's exertional and etc. So you're not concerned. I mean, you could say, what's the prevalence out there? But at the end of the day, you're dealing with this one patient. Okay? So what would you say? My guess would be 90% or so. But what if you said, but I think it's 85? Okay? Well, 85 and 90, it doesn't really matter that much. The only time it gets to be a problem is if you get really, really close to 1 or really, really close to 0. So what is this judging of the pretest probability called? What is that? It's called that process of pushing some diagnoses down and others up. Differential diagnosis, right. That's differential diagnosis. So you actually, what you're doing every day is estimating the pretest probabilities. You do it every single day with every single patient. You just didn't call it that, do you see? So so we've got our pretest probability, but what do you need in order to calculate the post-test probabilities? Well, you need 3 things. One is the pretest probability, another is the sensitivity, another is the specificity. Okay? Now, there are ways you can just do a 2x2 table, and if you have those 3 numbers, you can fill the 2x2 table out and get the post-test probabilities. An easier way is you can go to this medcalc.com and you can put in the prevalence, the sensitivity, the specificity, and you calculate, and then it comes up what's the positive predictive value, the negative predictive value, the positive likelihood ratios. I used to talk about likelihood ratios in previous years, but we've cut that in order to talk about the critical appraisal part. So positive and negative likelihood ratios are there if you want to learn about those. And then here's the pretest probability and the post-test probability of disease. Okay? So you plug these 3 in and you get your post-test probabilities. Okay? So on this man, we're going to give him that exercise stress test. And the exercise stress test, remember, had a sensitivity of 76%, specificity of 84%, right? So he has a prevalence or pretest probability that's 8.9. What is his post-test probability of disease if he has a positive test? 97%. So what would you say to the man then? You just had your stress test and it's positive. Would you feel comfortable saying, you have heart disease? I think at that point you would. Of course, what are you going to do next? What would you do after that? Yeah, you'd go to send him to cardiac cath. Fine. Now, what about this one? The negative predictive value is 0.28. What's the probability he still has disease even if the stress test comes back negative? 72%. And you say, but the test is negative. And you say, well, what are you going to tell the patient? Right, the test is negative, but there's still there's more of a chance that you still have heart disease. And in fact, Archie Cochrane, who created this, Cochrane database, he has this aphorism that says, if you're going to do the same thing if you have a positive test as you would do with a negative test, there's no point in doing the test. What are you going to do if it's positive? You're still going to send him to do the cardiac cath. What is it if it's negative? What are you going to do? Still going to send him. So in this particular patient, because the stress test has no ability to rule out, its sensitivity is so low, there's no point really in doing that. You just take someone like this drug. Anyway, so the 1 minus negative predictive value is 2%. Oops, no, oops, that's from a different slide. Sorry. Okay, now let's take a different patient, maybe a 40-year-old woman with anxiety and not really much in the way of risk factors, and you think that she comes in with chest pain. You estimate that her pretest probability is 0.1, okay? And then now you have the sensitivity and specificity. You plug it in, and now what is positive predictive value? 34%. And you said, wait a second, I thought the positive predictive value was 97% or 98%, right? From the other patient. But in this, I can't stand that. In this patient, can you trust the positive test? Would you say, I'm sorry to tell you, ma'am, you have heart disease? No, you couldn't. But what about the negative predictive values, 97? And here, 1 minus the negative predictive value is 0.3 or 3%, 0.03. And so you could reassure this lady, you don't have heart disease. So in this case, let's track these two and put them on the board here. So the first one, we started at 80 or 90%, okay? And we ended up high. Actually, we started at 90 and it ended up at 98, right? And then here, I plugged in the wrong number here. But anyway, this what's happening is here you can trust the positive test but not the negative test, right? And in this case, if this 1 minus negative predictive value is 53%, you'd say, no, I can't trust that. Okay? And what are all these people from here to here? Those are all the false negatives. And you have to be very careful because those false negatives are the ones who suffer. If you send someone like this out and he really has disease and he has a negative test, he might come back with sudden death. Okay? Where this lady here is a different scenario. You're starting very low, right? And you can trust the negative test but not the positive test. Why? Because here, these are all these false positives here. Okay? And so you can't say that she has heart disease too. Okay? Now, let's look at a different example, the HIV test. Now, down here, you can see the sensitivity of the HIV test is 99.5, and the specificity is 99.9. Is that high? Yes, you can say that's very high. Okay. Now, what happens if you start with a reasonably high pretest probability? Look what happens. This is not pulling the positive and the negative predictive values around much. Okay? Even if you go down to 1%, which is almost zero, what happens? It does begin to pull it down when you get way, way, way down there. But the effect, look at the effect of this. You see this? Here, because its sensitivity and specificity are so low, the pretest probability is pulling them all over the map. Okay? But here, because the sensitivity and specificity are so high, the pretest probability does not have as much an effect. Okay? Now, question is, do I need to calculate the positive and negative predictive value for all my diagnostic test results? What do you think? You think you need to do this every single time you get a diagnostic test? Well, even if you should, you wouldn't, right? Who has time? When should you actually do this calculation? Get your iPhone out, go to that website, and put in your pretest probability and the sensitivity and specificity. When? What's that? With new tests, okay, fair enough. If you're not sure how they operate, sure. But the situations when you should consider doing this in clinical practice is when you think the patient has the disease, and the test is negative. You look at the patient and I'm sure they have the disease, so I send the test and it comes back negative. You see the problem? You're starting with a high pretest probability and it's negative. What do you have to make sure is very high if you want to trust that negative test? The specificity or the sensitivity?
Sensitivity.
You would need to have a really, really high, highly sensitive test in order to believe that negative test. Like that HIV test. Remember, you start at 60 and you're ending up down below 1%. But if the sensitivity is 90% or 80% or even 95%, it may not be enough to push that negative predictive value enough to trust it. Okay? The same thing, when you are sure the patient does not have the disease, they don't look like they have the disease, and somehow a test is sent and it comes back positive. Those are the situations in which you ought to run these numbers, and go to that website and just check it. You don't want this to happen, the false negatives and the false positives, to make a fool of you as a physician. Okay? All right. I'm going to switch gears now. That's a quick review of sensitivity, specificity, positive and predictive value, the effect of pretest probability, and how you begin to use that in clinical practice and clinical decision making. I didn't get into likelihood ratios at all. There's just no time. I'm going to now switch to critical appraisal of a diagnostic test validation study. And, we'll be doing one in the seminar, but this is a brief overview of what you need to look for in such a study. The key components of a validation study are as follows, and I want to reiterate something I've said in some of the small groups, and that is, when you have a paper, you don't read it like a novel. Okay, you don't read page 1, then page 2, then page 3, all like that. What you're doing actually is you have a list of questions in your mind, and that list of questions, they're burning to be answered. You know something about the structure of a paper, and you say, okay, I need to know whether there's a gold standard and what the nature of a positive and negative result is defined as. Oh, I know where to go find that. So you go look, and you look that up, and you find that. And sometimes when you're answering one question, you bump into the answer of other questions. But I've also said sometimes some people read the intro and the discussion. They skip over the methods and the results, right? But what we're trying to do is to help you say, forget the intro, you already know all that, and forget the discussion because that's the author's spin. Focus mainly on the methods and the results and come up with your own conclusions. Okay? So these are the questions that you need to find out about in critical appraisal of a validation study. So you need to find out about the gold standard. What's the nature of a positive and negative result? Or how do they define disease? Second thing was the comparison blinded? Third, is there independent ascertainment, or rather, it shouldn't be independent. Independent tests. The tests should be independent of each other. And then number 4, the gold standard is obtained in all the patients or participants. Next, the test, the nature of the positive and negative result, the population. This is really, really important. Is it well-defined, clinically relevant, and unbiased? And then the results are the sensitivity, specificity, positive and negative predictive value presented. And then is there an ROC curve or likelihood ratio? And then are 95% confidence intervals included? We're going to go through all of these. So we'll start with the gold standard. The primary prerequisite of validation is having a gold standard. And in order to evaluate how close a test is to a true result, one must measure the test results against what you consider the truth. The problem is that some diseases are not that well defined, or they're diagnosed over a period of time, or they don't really have a very excellent gold standard. Okay? Sometimes you need multiple tests or observations over time for diagnosis. Let's look at a couple examples. So here, let's look at iron deficiency anemia. So what's the gold standard test for iron deficiency anemia? It's a bone marrow biopsy, right? So you go to crunch, you get it out, and you look under the slide and look for stainable iron. And you can tell that's considered a gold standard test for iron deficiency anemia. Now, it's diagnosed immediately, and it's a good gold standard test. How about myocardial infarction? It's not so easy or simple as that. There are multiple diagnostic criteria. You have chest pain, EKG changes, enzymes. This is not as well defined, is it, as a bone marrow biopsy. Furthermore, it's diagnosed over 24 to 36 hours, and it has to meet, what do you do if the enzymes bump, but it doesn't go up above a threshold, and there are EKG changes, etc. So this one is not as well defined, but if you're doing a study on MI and you're diagnosed in some kind of diagnostic test for MI, you need to make sure that the paper explains exactly their criteria for what makes it an MI. Okay, what their diagnostic criteria for the gold standard was. Let's take systemic lupus. It's not well defined at all. You have 7 criteria and you need 4 of them, and so you have malar rash and joint inflammation and serositis and immunologic involvement and so forth. But it could take years to diagnose, right, under the gold standard criteria. So you can see different diseases are going to have different challenges in terms of the gold standard. And then there are different types of gold standards. There's a continuous measure. If you have something that, let's say beta-HCG, which is continuous, you have to say, what is the cutoff to say that the beta-HCG is positive or negative? Okay, we'll talk about that cutoff. Sometimes there's subjective classification, like diabetic retinopathy. You look in there and you see some diabetic retinopathy. How do you grade it? How do you say it's there or isn't there? Is it there to a heavy extent or not? Okay? So the first thing is understand the gold standard, and do you feel comfortable with the way, the criteria that they use to diagnose the disease, to say these people are diseased, these people are not diseased. The second criterion is that the comparison must be blind. Okay? The person performing the test should not know what the gold standard result was. And they need to explicitly say that in the paper. This is particularly true if there's a subjective component to either test. If there's judgment involved, especially. But in any case, every study should be blinded, if at all possible, too. So here's an example. There's a new screening blood test for cervical cancer. Okay? And they're testing it against the pap smear. Okay? So what do you think would happen if the reader of the pap smear knew what the test result was? Yeah, if he knows that this pap smear was positive, if the test, this new blood test was positive, above the threshold, what might happen when the pathologist is reading that pap smear? They may push them like this. Oh, he would have otherwise read it as negative, but it's kind of borderline, and so he knows that this test was positive, so he's going to move some people from here to here. And then if they know it's negative, they're going to move some people from here to here, right? Now, tell me what's going to happen to sensitivity in that case. What's sensitivity? A over A plus C. This is getting big, right? And this is getting small. It's going to bias it upward. What's it going to do to the specificity? It will also bias it upward, you see? A and D get big, and your sensitivity and specificity say, mashallah, this is a great test, right? So, this is called diagnostic suspicion bias or expectation bias. There are lots of names for these biases, which I don't really care about the name as much as you understand how it works. So what has to happen is you have to cut this. You have to cut this so that whoever's measuring the test should not know the result of the gold standard. Whoever's doing the gold standard should not know the result of the test. And in fact, it's the same figure that you could use for a randomized trial and a cohort study and a case control study if you can. Let's say this is disease and not disease, and this is exposure and non-exposed. So the idea is, in a randomized trial, when you're measuring the outcome, you shouldn't know what the exposure was. And whoever's measuring the exposure shouldn't know what the outcome is. Okay? All right. So that's the second rule. The third rule is that the tests must be independent of each other. Okay? The tests must be independent of each other. So the gold standard should not incorporate the test under study into it. You say, well, that doesn't make sense. Well, it may not be as unusual as you think. Think of an MI, okay? The gold standard is chest pain, EKG changes, and enzymes, right? Now suppose, and that comes from a medical record review or something, and so suppose that there were, and if you're testing troponin I, right, to see how well troponin I predicts or diagnoses MI, right? So, but maybe some of the cases in these enzymes incorporated troponin I into it. See, troponin I was part of the diagnostic criteria. In that case, what's going to happen? What's going to happen if troponin I is included in the cases? Yeah, the troponin I will predict itself. If you measure troponin I, it'll be positive, but it's also positive in the case. So A gets big, right? And so, surprise, surprise, troponin I identifies itself because MI is being defined with troponin I as part of it. So you just want to double check, ask the question, is this test incorporated into the gold standard or not? If it is, it will be biased, for sure. Okay? The fourth criterion is that the gold standards must be done in all participants if possible. Now there's some times when ethically it becomes questionable whether you can do that, to do the gold standard in everybody. If that's the case, what some studies will do is they'll do the test, and if it's positive, then they'll do the gold standard. But if it's negative, they won't do the gold standard. They'll wait or do nothing or wait and watch. Okay? So think of this. Is it ethical to do an invasive procedure, the gold standard, on someone that you really do believe is not ill, just so that you can get an unbiased result? Let me give you an example. So let's say there's a new test, helical CT, for diagnosing appendicitis. So what you're going to do is get all patients presenting with fever, right lower quadrant pain, and anorexia with a possible appendicitis, okay? So you've got this group of patients. And what the study would do is to do the helical CT on everybody, and if it's positive, I mean if it's abnormal, they do the laparotomy and appendectomy if it's inflamed. If it's normal, the study investigators might say, well, we know what CT can do, right? And so if the CT is truly negative, if there's no inflammation whatsoever down near the appendix, is it really ethical, even though we're testing this to see if it works, is it really ethical to go and do laparotomies or surgery just so we don't have a biased result? And that sometimes in those cases, the answer is no. Okay? So what happens is if it's completely normal, they may do nothing or follow clinically and sometimes do a less specific test. Okay? What happens, though, to your sensitivity and specificity if you do this? You see, if it's positive, you're going to do the gold standard and find out if they're positive or negative. But if it's negative, you do nothing. Everybody you're going to assume is not diseased, right? What just happened to sensitivity? Actually, it goes to 100%, right? And what happens to specificity? It gets bigger, okay? So this bias can be large and serious. So and this bias, by the way, is called verification bias. Verification bias, when not everybody gets the gold standard. You don't see it that often, but there are studies out there that have this. And you have to be aware that if that happens, there's a big potential for bias. Okay? So we've talked about the gold standard and the criterion associated with that. Now let's talk about the test. Okay? The fifth criterion here is that the definition of a positive test needs to be given. And just like the gold standard, you need to understand the criterion for how they call people diseased and not diseased. In the same way, you need to see what are the criteria they're calling for a positive test. So if it's a continuous measure, you say above this point it's positive, below that point it's negative. Okay? And if there's subjective classification, you have to see what are the specific subjective classification that would say someone has diabetic retinopathy versus not. Okay? Now, another thing you want to look for, and I don't have time to go into this, but is the reliability of the test should be given. What's the difference between reliability and validity? Well, I'll tell you what. Why don't you answer 5 to my questions? Okay, and no need to embarrass him, but what's 2 plus 2? No, say 5. What's 2 plus 2? What's 2? Well, no, we need you to be consistent here. What's 2 plus 2? What's 2 plus 2? What's 2 plus 2? What's 2 plus 2? Is he accurate?
No.
Is he precise? Yes, that's the difference. Okay. Precision is how closely do the results cluster to one another on repeated measures. And sensitivity, specificity measure accuracy, okay? But the reliability or precision of the test is measured by various things. One is called coefficient of variation for continuous tests and kappa for categorical tests. I don't have time to explain those. But in a study, you should look for them and say, well, what's the precision here? What's the reliability of this test? Okay? That's different from, oh man, I'm going to break this thing, I'm afraid. That's different from saying, is it accurate? Is this result close to the truth? Okay? All right. So we've talked about the gold standard, we've talked about the test. Now we come to something that's really, really important. It's called the population. And a lot of people, when they do PICO, focus on the exposure and the outcome, and they forget about population. But it's really important for the idea of saying, do I have the right to apply this paper to my patient? Because if the population is very, very different, I may not have that right. So you have to know, and this goes for randomized trials, cohort studies, any study design, you need to know who is in this paper. Take the time to figure out and clinically understand and visualize what that population of people is in this paper. And then ask the question, could my patient be in that population? Or is there something about my patient that doesn't fit, that doesn't allow me to generalize this paper to my patient? So, true or false? Positive and negative predictive value are affected by the prevalence of disease, or the pretest probability. Is that true or false? True. I already explained that. Now, here's another question. Sensitivity and specificity are affected by the prevalence of disease. True or false? False. Okay? But are sensitivity and specificity affected by the nature of the diseased and the non-diseased in that study? The answer is yes. And so while prevalence itself does not affect sensitivity and specificity, if the nature of the diseased people in a high prevalence population is different from the nature of the diseased and non-diseased in the low prevalence, then you may have a problem. Okay? And I'm going to explain this a little bit. But technically, prevalence does not have an effect on sensitivity and specificity. But the nature of the people in the study can have a huge effect on the sensitivity and specificity. Now, first thing you have to say is the population well-defined clinically relevant, not cherry-picked, but clinically relevant and unbiased. So a well-done validation study should clearly define the inclusion criteria, okay? Include those in whom the test will be used, which is the target population of the test. Everyone in this study should clinically be a candidate for the test. If they are not, you have what's called a spectrum bias, okay? So the steps in identifying who should be in the test is this. First, think through the clinical situation in which you would be doing the test. Whether it's a diagnostic test or a screening test, think through the typical clinical presentation and say, those are the people who should be in this study. Okay? So identify the typical non-diseased and diseased, right? What that means is if someone comes with chest pain, you have a question. Is it cardiac pain or not? Right? So you don't know, but that's the point at which you say, that's the person who should be in this paper. Okay? And the best way to identify participants in such a study is to identify consecutive patients who are presenting with a predefined set of symptoms to catch the full spectrum. Okay? You want to get everybody who would be eligible for that test to be in the study. And beware the study that cherry picks the cases to be more severe and the controls to be less severe, or including people who would not be eligible for the test. Then you have a problem. Okay? So here's some examples. If the test is used to diagnose symptomatic patients, make sure all the patients come from the usual clinical pool of patients with the symptoms of the disease before they're diagnosed, not after. For example, consecutive ER patients with chest pain of undetermined origin. If the test is to be used as a screening test, then you need to make sure that everyone who comes into this study is asymptomatic, because that's who you're going to be getting the test to. There's no point in getting diseased and non-diseased people, like a case control study, and then saying, oh, that the sensitivity and specificity for its use as a screening test is the same. No, it wouldn't be. Okay? So beware the diseased group. The diseased people in the study must represent the full spectrum of disease who are eligible for the test, and the same thing for the non-diseased. If these conditions are not met, spectrum bias will be very likely. Here's an example. Here's some new test for MI. Okay, and it's a continuous test. And what they're going to do is to take people who have been diagnosed with MI, and then normal controls without chest pain. Okay? And look at that. You know, you say, I'm going to cut point here, which means above this line, I'm going to say the test is positive. Below this line, I'm going to say it's negative. Now you tell me, can you see from this, what is the sensitivity of this test? How would you calculate or estimate the sensitivity of that test? Of those with the disease, what percent test positive? Where are the diseased? Here. What percent of these people are above this line? They're testing positive. Estimate. Would you say 98% or 99%? So very, very high sensitivity. And then what's the specificity? Of those without the disease, what percent are testing negative? Almost all of them, 95%. MashaAllah, this is a very good test. Right? What's the problem?
People without chest pain.
Yeah. Would you ever give this test for MI in people who are just walking around normal? Wrong patient group in the study. They shouldn't be in here. Because who are the non-diseased who you would be giving the test to? Is those people with chest pain or unstable angina or some other, GERD or something like that. Now, it turns out that this test is much higher in those people with chest pain from other causes. Now what's the sensitivity and specificity? Much lower. Do you see the problem of including people in the study who would not ordinarily be eligible for the test? Okay? Now, let's look at another example. We're going to use this as a test for diabetes. So you go to the diabetes clinic, and this is some new test, and you're going to compare the people in the diabetes clinic to obese people without diabetes. And you say, I want to use this as a screening test for diabetes among obese people. So you say, look at that, high sensitivity and specificity. You have nice separation of those two groups, right? What's the problem? Would you ever screen diabetics in a diabetes clinic for diabetes? No. So they shouldn't be in the study. Who are you actually? You're going to be doing it among undiagnosed diabetics. And the undiagnosed diabetics are less symptomatic. They're asymptomatic. So now look at the test. It's terrible. You see? So it's extremely important that you understand and clinically define who are the people in here. And if there are people in this study who would not be eligible for the test, it will be biased. Okay? That's called spectrum bias. All right? Beware the case control study. Case control studies are extremely dangerous when it comes to diagnostic testing because you have to get your cases, you have to get your controls. The cases have already been diagnosed. So they're the most severe people. They're not really the people who you're going to be doing the diagnostic test on. Unless you got them right when they were immediately diagnosed, you might be able to do it. But the problem is, where do you get the normal people? And sometimes completely asymptomatic people are being chosen for these studies. And they say, look at that, it's really high sensitivity and specificity. If you're going to do it, the cases must be newly diagnosed and where you're doing the test at the same time as the usual diagnosis. And then the controls have to be people who have the symptoms of disease, but you're not sure whether they have it or not. No, you'd have to get non-cases who had symptoms. Do you see how difficult that would be to do a case control study? But there are studies out there like this. There's a high risk for spectrum bias in such a study. Okay? We're going to finish up with the results. You want to make sure that sensitivity, specificity, positive and negative predictive value are presented. Okay? Now, sometimes positive and negative predictive value are presented for different disease prevalences, but I'm going to make a statement: never apply a positive or negative predictive value from a paper to your patient. Why? Why wouldn't you say, well, the positive and negative predictive values, what affects positive and negative predictive value? The pretest probability, right? So if the pretest probability of a patient is different from what it is in the study, that's going to be a problem. You can't apply that to your patient. The next thing is ROC curves are presented. If a diagnostic test is continuous, then what you can do is to generate this ROC curve with different cut points along the line. So let's consider this test, this M-Izyme test. You have to decide where you're going to turn it positive, right? So what you do is you say, well, I'm going to try it down here. How high is the sensitivity at this cutoff? How high is sensitivity? Very, very high, almost 100%. How high is specificity? Maybe about 30 or 40%, right? Does everybody see that? Of the non-diseased, the green people, they're not from Mars, but only 30 or 40% are testing negative, so the specificity is very low. Then you say, okay, let me make the cutoff here. What just happened to sensitivity? Sensitivity went down, but what happened to specificity? It went up, okay? And then we go up here, what just happened to sensitivity? Now sensitivity is almost down to 30. And what happened to specificity? Now that's 100%. So what you have is this trade-off between sensitivity and specificity for every single test. And what you can do is graph this in an ROC curve. What happens is, the higher the threshold to call someone diseased, the higher the what? Specificity. The lower the threshold to call someone diseased, the higher the sensitivity. Okay, so this is the ROC curve actually from the paper that we're going to be studying in this seminar. And if we look, on this axis is sensitivity, and on this axis is 1 minus specificity. And I think those clinical epidemiologists wanted to twist the knife with this 1 minus specificity, just so the curve went like that instead of like that. But what I recommend is just scratching out 1 minus specificity and just put specificity, put 100 here and 0 there. It'll be easier to understand. So when you move from the right over to the left, is specificity going up or down? The specificity is 100% over here. So it's going up this way. So, and then sensitivity is going up this way. So which of these points, A or E, has the highest cutoff? Sounds like egophony. E to A change. Okay. A, the higher the cutoff, the higher the specificity. See, this specificity is 0 over here, it's 100% here. And the lower the sensitivity, 100% sensitivity is here, this is now down to here. Do you see? So A is the highest cutoff, and E is the lowest cutoff. Okay, got it? And then, so this is actually 99% cutoff, this is 70, 50, 30, 1. Okay, so now, the better the test, the closer it gets to this corner. Like the HIV test goes like this. It goes down like that. The higher the sensitivity and specificity, the closer it is to that. But the point is, the diagnostic test manufacturers have to choose where the cutoff is going to be. Or, for this is narrowing of coronary arteries. You have to decide, where are we going to call it heart disease versus no heart disease. If you say 70% cutoff, if they have 65% narrowing, it's negative. Right? Does that make sense? But if you're going to do sensitivity and specificity, you have to choose a cutoff. Okay? Now, things like likelihood ratios get around that, and they give a separate number for every cutoff, and the likelihoods get higher and higher and higher, which is an advantage to likelihood ratios, but we don't always have information on that. The last thing is confidence intervals are presented around estimates. Watch out. Many of these diagnostic test studies are woefully underpowered, and they have very wide confidence intervals around the sensitivity or specificity. And even many studies don't even report the confidence intervals. It's amazing that editors allow these things to be published like that. Remember that the 95% confidence interval includes all the values that are consistent with the truth. So when you see that confidence, the truth could be, with 95% confidence, anywhere in that interval. The estimate is still the best estimate, but the truth could be anywhere in the interval. Okay? This is just a website. I think it's in your handout with all the websites that you can do for those EBM calculators for positive and negative predictive values. Okay, thank you, and we'll see you in a few minutes then in the seminar.
All right, nobody goes anywhere. Close the doors. Yeah, it's photo time. So those who are interested, I would love you guys all to come in. So we'll get organizers from outside, because hotel staff, to get us some chairs on the candle. Mark lamps.
بس حسن اوكي والمار
برهان
بس تيك توك قاعد تصوري
لا في ريفلكشن
كلكم طالعين بالصورة
Don't be worried. For this last talk, there's nothing really critical for you to learn. It's more presenting you a few reflections on how to use and how to put it fruit what we learned during these very dense 3 days. So the objective for this last lecture are to review a few concepts about medical literacy, how much doctors understand about risk and about effects, and how to communicate those risks and those numbers. And finally, I will go quickly over pre-appraised evidence, so what you can find that save you time when you search for good literature. I start by citing Sir Muir Gray, one of the founders of the evidence-based movement, who compared what was the effect in the 19th century of introducing clean and clear water in many Western countries with a tremendous reduction in the rates of infection, as what clean, clear knowledge will be doing in the 21st century to healthcare. Is that true? Gerd Gigerenzer, another huge presence in the EBM panorama, is a bit more cautious, saying that most doctors and most healthcare providers, most patients, they do not understand health statistics. That's why we have courses like this. And if you ask around, they did a few years back a survey in Europe presenting data on the effectiveness of a cancer screening and asking if they were considering the intervention effective or not. And they were asked to rate how important was the effect of the screening, and was a normally effective screening, so it was nothing exceptional. It was saving some lives, but not having a huge risk reduction. And in many cases, the overestimation of the efficacy of the screening program was extremely high. To give you a more easy to understand example, I cite Rudy Giuliani. I took these slides actually from a presentation delivered this year at the Cochrane Colloquium. He was engaged in his re-election campaign while he was diagnosed cancer. And then he stepped down, and then he stood up again later. And he presented, in supporting the American policy, a sentence like this: I had prostate cancer 5 or 6 years ago. My chances of surviving prostate cancer, and thank God I was cured of it, in the United States, 82%. My chance of surviving of prostate cancer in England, only 44% under socialized medicine. Does this make sense? Well, it does not. But do you expect only Rudy Giuliani, which is an intelligent person but not a technician, not a doctor, would be misled by looking at the data he was looking at? Fahd named in this introduction the lead time bias. So if you look at two populations that both start cancer here and both get to death at age 70, if you don't screen, you will see cancer coming up on average at 67, and you will have a 5-year survival of 0%, because everyone is diagnosed late. And so, from the diagnosis to death, you have less than 5 years. If instead you do screening, you diagnose the cancer here, and 5 years after, everyone is alive. Survival 100%. But at 70, everyone is dead.
So in the end, you don't affect the health of this population, you just anticipate when you do the diagnosis. And the 5-year survival after screening changes from 0 to 100%. This is called the lead time bias. Not only, but if you consider a population without screening, and you have